Happy December 23, 2022 to all of you, or December 24, Christmas Eve for my friends down under. Surprise! This is the bonus one. I just could not resist the chance to be with you again. I love our times together on these Fridays. And so, welcome to the final. Now, this is the final episode of 2022. SADS Live number 108. I'm Mike Ackerman, genetic cardiologist and the director of Mayo Clinic's Windland Smith Rice Genetic Heart Rhythm Clinic and our Windland Smith Rice Sudden Death Genomics Laboratory. And as in the previous 107 episodes, I'm here on behalf of Alice Laura, and I give you greetings from Alice, our CEO of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, where those who have been with us know that the whole purpose of our nonprofit advocacy organization is to be there for families with genetic heart conditions, with SADS conditions of long QT, Brugada, CPVT, ARVC, Timothy syndrome, and others, where this is your home. And I hope you have found it to be home, and where our intent is to do everything we can to help you live and thrive despite your SADS condition. And so we thought earlier this week, I said, well, why aren't we going to meet on Friday? Because these are Friday get-togethers are some of my most favorite times of the week. I love being with you. I love the community that we have and to participate together in this journey called life. So welcome. And we see what questions you might have or comments that you have. I'll show you, maybe you don't see it, but I'm going to reach back here. A gift from my PhD students for Christmas. And how do you like that? So Minnesota Vikings, this just could be our year. So I want to thank my graduate students for giving me this very special gift. So I hope you are on your way to receiving a special gift or giving a special gift. And may the season upon us truly be one of the most blessed ones that you've experienced in your life. What questions do we have? Let's see. I want to see who's joining me too. Julie, hello, Julie. So Julie wants to start it off with her joke, and I've heard this one, I must confess. Well, how do you describe a cardiologist's ugly Christmas sweater? Tacky, as in tachycardia. So that's a good one, Julie. But now she gives her serious question. It's her only one of the day, and she's wondering about a link between a frontal lobe type of epilepsy and long QT syndrome. It's a really good question. There's a lot to discuss there. The specific answer is no. There is no link between frontal lobe epilepsy and long QT syndrome. But there's an interesting thing that our program discovered and others have seen as well, is that we reported quite some time ago that we would have patients with long QT syndrome get described as having a seizure, get diagnosed as being epileptic, get placed on anti-epileptic medications, when for all that time it wasn't epilepsy doing its thing, it was the long QT heart doing its thing. And then after the faint, then the brain becomes electrically ticked off, and then the brain shows seizure activity. But the cause was the long QT heart misbehaving. But then we noticed that this description of seizure-like activity was far more common in patients who had the genetic label of LQT2 compared to the most common genetic version of long QT of LQT1. So we'll wonder why is that? Why would they be more likely to be having been labeled as having seizures or being called epileptic? And then it was discovered that the same gene that's responsible for LQT2 expresses the same potassium channel in the heart, but in the brain as well, particularly the temporal lobe and the hippocampus, not the frontal lobe. So it is possible that some of our patients with LQT2 are actually having true neurologically, centrally mediated, brain mediated electrical misfit adventures of epilepsy. But for the most part, the most common connection is the long QT heart doing its thing when it misbehaves. And if it stays doing its misbehavior of torsades, then secondarily, the brain gets electrically ticked off and shows generalized seizures. I hope that was helpful for you. Great question to start our final Q&A of 2022. A question from Andrew, and I'll take it as I always do, from top to bottom, no sneak preview, no preparation. And it's getting harder and harder because you guys are amazing with your questions. But Andrew's wondering, does the KCNH2 subrep gene therapy for long QT possibly suggest that there may be therapy on the horizon for Brugada? Well, we'll know a lot about the state of gene therapy for the long QT syndromes in general, genetic heart diseases in general in 2023. We're going to have a good feeling by end of next year whether we're onto something with our specific form that we've discovered at Mayo Clinic called suppression replacement gene therapy. There are other replacement-only gene therapy strategies that are going on, for example, by the company Tenaya Therapeutics, rolling out in 2023 and enrolling patients with a particular form of hypertrophic cardiomyopathy called MYBPC3. And there are others to follow. The challenge with Brugada syndrome in terms of gene therapy is, remember, only 20% of all Brugada syndrome is one gene mediated, monogenetic, sodium channel mediated. And right now, a gene therapy solution for sodium channel mediated Brugada syndrome is going to be challenging because that gene does not fit in the current cargo delivery system, if you will, of the AAV9 gene therapy vector that's used. So we're going to need to have some new advances before gene therapy will be possible for the sodium channel version of Brugada syndrome. Juan is asking about, is Augmentin and dexamethasone safe for long QT patients? That's a great reminder, Juan, about the incredible resource from Dr. Ray Woosley of the Credible Meds app, www.crediblemeds.org. You can go in the app library and download Credible Meds app. And there, where I use it the most for my long QT patients is that in most situations, if there's a prescription medication that is on the QT drug do not take hit list, then we should be careful. That doesn't mean never. I have many patients with long QT syndrome who are on medicines on that hit list. And so it depends on what's the risk benefit, what's the upside and downside, careful decision making. There are also over-the-counter medications that have found its way on that hit list, and there I'm much more relaxed. They almost never cause a QT problem, and so I don't want my patients miserable with the cold because they're afraid to take a sinus medication because that over-the-counter is on the list. Just don't stack the deck with multiple ones that are on the list. Now, specifically Augmentin, you won't find that one on the list if you look it up because that's just amoxicillin and clavulinic acid. It's an antibiotic, and that antibiotic is QT safe. Same as with the steroid medication, dexamethasone. So those two, if you look up on that list, you would not find them there because there's no credible evidence for there to be a QT signal. And Sarah Jane, hi there, she's sharing that she has a VUS, variant of uncertain significance, in the RYR2 gene. And her brother died in his sleep. I'm really sorry to read that. Great uncle, accidental drowning. Your son has that genetic marker. You've had negative stress tests, although you've passed out before. My son is only being followed. Is that enough? I worry he needs preventative treatment. Great question. So a couple things there is we have work to do because we have to decide, do we think your VUS is actually a CPVT1 causative variant or a calcium release channel deficiency syndrome causative variant? Meaning, do we think it's pathogenic even though the genetic test company, they have graded it a VUS? The story sounds certainly suspicious. And so I would want to know, for example, the great uncle who had the accidental drowning. So that would either be your mom or your dad's side. Does your mom or your dad, therefore the one related to the great uncle, is he or she positive? And then what does that person's stress test look like? And then when you both have had negative stress tests, I'd want to know what kind of stress tests. Work from Canada and my friends, Dr. Shu Sanatani and Andrew Cron and others. And remember, we're going to have in the new year the Canadian version of SADS Live, eh? So that's going to be exciting, and I can't wait to join them for that. But I digress. What they've shown is that maybe we should do a different kind of stress test rather than the standard one. So I might want to see what your son and you look like on a normal stress test, and then what you might look like on what's called the burst protocol stress test. But if that is normal and the Holter is normal, then our drill probably would be to just watch every 6 to 12 months and redo the drill. We might want to try to partner with a research laboratory to functionally characterize your variant, just in case it is the other rarer version of RYR2 disease called that new kid on the block, calcium release channel deficiency syndrome, for which the stress test is normal. And so there's work to do for your family, and if we could help, it would be a privilege. Julie misspoke. It was temporal lobe. So now you know the full answer, Julie, and Merry Christmas to you over there out east. Jenna is asking about her notch T waves in V4, but no electrophysiologists are concerned, including the great Dr. Andrew Cron, dear friend of mine, our third Mayo Clinic Winland Smith Rice genetic cardiology professor here last year. Because I'm not prolonged. Is this common? Cardiologist brought it up, but Electro says it's common. So it depends, Jen, on what we mean by a notch. So it's kind of back to that. It depends on what the definition of is, if some of you Americans remember Americana history from a few presidents ago. But anyway, if your QT is not prolonged, then that look in V4 isn't that informative. So Dr. Andrew Cron is probably spot on his lack of concern being assigned to that. There's a few different looks. So there's sort of the normal notch look, and then there's the suspicious LQT2 notch look, and they have different looks. It's kind of like that expression of, how do you know that was Aunt Minnie who crossed the street? Well, because it looks like Aunt Minnie. And so I'm suspecting when Dr. Cron looked at it, he thought it was probably the boring looking notch and not the concerning one. And then the next question coming through. Oh, and they're flying in now. Lisa, a great name. That's my wife's name. Just celebrated our 34th anniversary a week ago tomorrow. So your question is an 18-year-old male with normal electrocardiograms, even with high lead placement. That's putting the leads up the chest. So that would be something for you all that somebody's thinking the possibility of Brugada, or during fever. Parent and 2 siblings have Brugada syndrome. How often and for how many years should we get these EKGs, or would I do a Percanamide challenge to see if these screening ECGs can end? Oh, good question. Well, the first thing that needs to be done is the parent, whoever in that family clearly has Brugada syndrome, the one that you would bet the most, that person needs the Brugada syndrome genetic test. If that Brugada syndrome genetic test is cleanly positive, then everything's easy. Test the relatives, dismiss those who test negative and have a normal ECG, and keep those who have a positive genetic test under surveillance, whether that surveillance is every 6 months, 12 months, 24 months, 5 years, some semblance of surveillance. So let's make sure we've got the genetic test that was done currently. If we're stuck and the genetic test is negative, then all of the appropriate first degree relatives need to have some surveillance of the high lead ECG. And I actually wouldn't bother with the procainamide. You could do it, but if you're procainamide positive, we would tell you avoid the Brugada drugs. If you are high lead positive, we'd tell you to avoid the Brugada drugs. If you own the genetic marker, but you have a normal ECG, we would tell you to avoid the Brugada aggravating drugs and no marijuana, no getting drunk, and no cocaine. So maybe a killjoy as well. So Lene, oh, one of the sweetest families in the world. Ellie, hi Ellie. She had the COVID vaccines. Whew, so now let's get controversial, huh? She had the 2 first shots, so did I. Do I recommend that she gets boosted every time a new booster is available? And thank you and Merry Christmas to the best cardiac. Oh, thank you. Well, we've learned a lot, haven't we? Some things we're proud of in medicine, other things, ooh, we took some corners. Lots for us to learn and reflect back on in this thing called the COVID-19 pandemic. Remember, SADS Live was birthed in February of 2020. It's going to be 3 years ago. In the midst of the chaos where we were a lot of uncertainty, a lot of fear, a lot of anxiety. And it's been good to see during these almost 3 years that there is not 1 inch of a signal in long QT syndrome that either the virus or the vaccine against SARS-CoV-2 has resulted in an increase of long QT triggered episodes. Not a single hint of it. We're publishing this. I gave you the punchline, not a single hint. Also, not a single hint of a marked increase in Brugada, although if the vaccine or the virus produced fever, then maybe there's been a slight increase because of the fever trigger connection. So for all of my long QT families, whether you get vaccinated or don't get vaccinated, your long QT has nothing to do with that decision. So then you should just weigh it in the balance like every family is. And I can tell you that in my own family, not all of our kids are fully vaccinated. In my case, I received the first 2, had to. I had the first booster. I got OMA crushed a year ago now about. And so I have not stayed on my booster series, follow-up boosters when I'm time eligible. And I don't know that I am. I'm waiting to learn more because I have vaccine-associated immunity from my 3 shots, and I have the virus and natural immunity. So I'm kind of good where I'm at right now. I did get my flu shot, just like I do every year. But again, I had to by our hospital's requirements. So influenza vaccine, I would for everybody. Whether you stay vaccine up to date for COVID-19, I think there's a lot of different things that weigh in the balance with that decision. And hopefully we'll know more. Maybe that will change in 3-6 months where the evidence is pretty clear that all of us should be vaccine current for COVID-19, or it may become clearer that only the fragile really need to stay vaccine current. And those of us who've had natural infection plus initial vaccinations, like me, for example, maybe we're good to go. Great one, Alice, and thanks for the sweet compliment. Allison, what's my thought on the value of a loop recorder in CPVT patients? Is there a trigger for determining time to place one and how long it should be kept? Well, Allison, I love the question. It's not just for CPVT. It could be for our long QT families anyway. So first off, I like the loop recorder. So that loop recorder is, I don't have one here in the room. It's a small, about the size of a dentine stick of gum. It gets injected right underneath the skin here. Very tiny, tiny incision. The battery lasts about 3 years. But I think we might be putting them in too many people. So I like them, but I like them only when I need them. And most of my patients, I don't need them. So I probably have utilized a loop recorder in, I would bet, less than 5 to 10%, oh, easily less than 10% of all of my 5,000 patients. So when do I use it? I use it when I don't like the story and I can't quite convince myself that that faint was a perfectly normal, unrelated faint or a worrisome disease triggered faint. And if I'm waffling in my conclusion about that, then I generally will use the loop recorder so that I have judge and jury present if there is a second spell of some sort. And so that's where I probably find myself using it the most. And then if I do choose to use it, I run it through its 3-year battery life. Oh, sweet. From Chef Cassie. I can't wait to come to your restaurant someday, Cassie. I did look you up when I was down there in Houston after your meeting, and your website is impressive. So congratulations. Proud of you. Jen is asking about pregnancy and being generally safe with SADS conditions. General rule, yes. In fact, the pregnancy issue is probably one of my top 10, if I gave a top 10 list of the myth busters or the cruelest expressions given to my families with SADS conditions. That would be one of them. It might be number one, actually, where I have had too many families who were told, thou shalt not get pregnant. Thou should not get pregnant because one, you shouldn't create a long QT baby, or it's dangerous for you to be pregnant. Nonsense. Cruel, in fact. So I have many, many, many long QT, CPVT, Brugada families, HCM families who've produced many beautiful children. Some with the genetic marker, some without. Guess what? About half yes, half no for each child, as we would expect. The practical risk to the mom during pregnancy is super low. In fact, for most of my moms, I don't even like calling them a high-risk pregnancy because I don't like the chain reaction that sets in motion for a lot of the moms and their OB and their healthcare team, where they kind of shift into freak out mode. So yes, pregnancy is generally safe. Christine, how common is sinus node dysfunction in the setting of Brugada syndrome with Brugada pattern? Your 12-year-old son has never had VT or VFib, but has slow heart rate, bradycardia with fainting, and a pacemaker placed because of it. At what point would a defibrillator be indicated? Oh my goodness, you guys are ending the year with amazing questions. So I'm assuming that your family's Brugada syndrome might be genetically known, and therefore it's sodium channel Brugada syndrome 1, SCN5A mediated Brugada syndrome. And what's kind of interesting about that syndrome is there's more often a prolonged PR interval causing some conduction delay than there is a slow sinus node. So it's possible that the sinus node dysfunction is related. It's possible it's not related. There is an entity within the sodium channel called progressive cardiac conduction disease, where there is sinus node dysfunction and AV node dysfunction as well. So I'm guessing that your cardiologist does not like your son's resting heart rate, probably means that it's less than 30 or less than 35, and they chose the pacemaker. But just because they might have chosen that for the slow sinus node doesn't mean the device needs to get upgraded for the defibrillator with the defibrillator component. So a patient like your description of your son may never actually need the ICD technology and maybe only needs the pacing technology. Babette is wondering about if there is new evidence of ANK2 gene mutation affecting the QT interval. It's a great question because ANK2, interesting gene, encodes an interesting protein called ankyrin B. And a long ago now, a wonderful group in France, I believe, described ankyrin B syndrome, which also got tagged as type 4 long QT syndrome or LQT4. And over the years, the strength of that evidence to call ANK2 a true LQT syndrome gene like LQT1, 2, and 3 has weakened. And part of the reason for the weakening of that evidence is there's just a lot of background genetic variation in ankyrin B in the ANK2 gene. So I personally have not convinced myself of ANK2 mediated long QT syndrome. I don't have a single patient family where I would say, see, this is the patient's cause of their long QT syndrome. So the evidence has weakened, but the evidence has weakened for other so-called minor long QT genes, the minor Brugada genes, for all of them, like in Brugada, as in 22 minor genes. Every one of those minor genes called not the sodium channel, those have actually been demoted to limited evidence genes, refuted evidence genes. So the case of causality in the field of Brugada syndrome genetics has really crumbled and has been challenged. Corey's wondering, and hi Corey, Merry Christmas to you, is how helpful is the data you receive from stress tests? Well, stress testing is one of the standard tests we use in most genetic heart programs, genetic heart rhythm programs. And the value of the stress test is incredible, but it's very disease dependent. In long QT syndrome, the stress test may help us decide, are we satisfied with the dose of the beta blocker, measuring the beta blocker effect. We use it to look to see if somebody shows penetrant LQT when the resting ECG might be normal. In CPVT, it's the most critical diagnostic test because the resting ECG is always normal. The stress test is one of the most important tests that we use on a regular basis. Sabrina's wondering, what do I have to consider when traveling abroad, especially in countries with poor medical care, and you're a CPVT family? I love that question. I think that's the first time we've had a question like that. What we generally advise for all of our families is to have a safety plan. What numbers would you call? If our families are without if it's a child where we've recommended the AED as safety gear, I expect that AED to go with them, just like it would be at the cabin or part of their sports gear if they're an athlete. But I'd also would say I don't restrict traveling to basically anywhere. So all of my patients for the last 20 years have gotten to travel basically anywhere they want to. And I don't even know if I can think of a single travel abroad episode that has happened to a patient who's under our watch being managed and treated. So hopefully that would encourage you to enjoy your travel and not worry about it. Does my pacemaker record the same info as a Holter? As a Holter is part of the protocol Mayo has planned for me. Not exactly the same. That's why in my patients who have a pacemaker, I'll often order a Holter as well, because I want to get a more precise snapshot of the 24 hours of electrical activity. Susan's indicating that her husband was just diagnosed with long QT after your daughter got diagnosed. What is the difference between LQT1 and LQT2? He was just prescribed a beta blocker, Nadolol 40 milligrams. So I'm assuming, and that assumption would be correct, about 95% of the time or more that you, your daughter, and your husband own the exact same genetic marker. And therefore, both your husband and your daughter have either LQT1, both of them, LQT2, both of them, LQT3, or LQT something else. The difference between LQT1 and LQT2 is a lot. They're the two most common genetic subtypes. LQT1 is most common. About 35% of all of our families have LQT1. LQT2 is second place at about 30% or so. Both of them, beta blocker therapy is the primary treatment of choice, works better in LQT1, works well in LQT2, and so forth. Your husband is on the beta blocker that I like the most for long QT syndrome. And I look forward to seeing you, Susan. While Paulo is wondering of whether Brugada can stay hidden on all EKGs for 40 years and then suddenly develop. Yes, uncommon if there have been, depends on what's the compendium of ECGs, but like long QT syndrome, how the QT can oscillate or vacillate, so can the Brugada pattern. The Brugada pattern is influenced by mood, if you will. It's influenced by vagal tone. The morning ECG on a huge breakfast is more likely to show the Brugada pattern than a morning ECG on an empty stomach. Fever, as you know, can bring it out. So there could be reasons why it stayed hidden and then is caught or comes out. But one of the things that's encouraging is when that ECG mostly stays hidden and pops out once in a while, like hide and seek, that person's risk is way, way, way lower than when that Brugada pattern is always, every time, every ECG there. And Lisa is wondering, why are Brugada patients with a fever at a risk of syncope? Well, it's not a risk. The risk is higher. It's not very high. So one of the things we know is that things that elevate the core body temperature makes that sodium channel, which already, if you have sodium channel Brugada syndrome, which is already a loss of function mutation where that sodium channel and that sodium current don't work as well, under higher core body temperatures, that channel works even less well. And so it's kind of a 1-2 punch: genetic reduction in the performance of the sodium channel, and then an acquired fever-mediated reduction in the performance of that sodium channel. Now, Victoria is wondering, why is it some of us cannot absorb magnesium unless it is combined with calcium as an ion channelopathy? Well, really good question, Victoria. The absorption of electrolytes, whether it's magnesium or calcium or potassium, has nothing to do with a person's primary channelopathy, long QT Brugada, or primary cardiomyopathy, LMNA, ARVC. So that's completely independent, because the absorption of those electrolytes are done in the kidney. And the kidney has very, very little expressivity of these channels. So these channels, while they're critical to the heart's electrical system, these channels that cause long QT syndrome have very little physiology, very little role in kidney homeostasis, magnesium absorption, reabsorption, secretion, and so forth. So that may be just cause, but nothing to do with a person's long QT. Mary's wondering about are there other things besides medications and hereditary that cause long QT syndrome? There's lots of things. So what I like to do is when we know it's running in the family due to genetic reasons, where we call you long QT 1, 2, and 3, that's called genetic long QT syndrome, hereditary long QT syndrome, familial long QT syndrome, congenital long QT syndrome. When the person has a prolonged QT interval, not because of genetics or running in the family, but just because of other things, then I personally like to call that acquired QT prolongation or exogenous QT prolongation rather than calling that long QT syndrome. Some people view that as a semantic. I think the difference is important because one has nothing to do with the relatives, the other might. And there are a lot of reasons why a person's QT interval could become prolonged in an acquired way. You mentioned medications, and that's the most common. That's why that hit list of drugs, crediblemeds.org, is so important. But there are other reasons. So electrolyte abnormalities can prolong the QT interval. Low body potassium can do it. Low body magnesium can do it. There's health issues, diseases, that can bother it. So, for example, patients with diabetes might have longer QT intervals than patients without diabetes. People who've had a subarachnoid hemorrhage, a head bleed, they could have a prolonged QT interval. Somebody who drowns, a normal drowning, nothing to do with long QT syndrome, but is surfaces, that submersion injury can transiently prolong the QT interval. So there's lots and lots of reasons. So that's why when we see a patient who has an ECG that incidentally shows a prolonged QT interval, we have to figure out the why. Is it because of a family genetic reason, or is it because of a large list of acquired or exogenous reasons? And with that, so Susan, we'll give Susan the final one. I think it's back up to maybe the husband who who's positive. Can he resume running after he's on Nadolol? He's told to stop until he begins his treatment. Well, that's a tough one because I'd have to know and understand the why. How impressive was the long QT? Why did we need to start him on medicine and so forth? But in general, in my patients who we stumble upon their QT incidentally or confirm it through family testing, as a general rule, I don't restrict them or limit them at all while we're dialing in the therapy because their risk is unbelievably low. Because after all, your husband had 30, 40, 50 years of life in an untreated, unknown state. And so it really depends on a lot of factors that I can't quite tailor to your husband specifically, but hopefully that gives you a sense. Well, that's a wrap. 2022 is almost in the books. SADS Live 108 has almost come to a close. And as we bring it to a close, I just want to say thank you. Thank you for letting me be a part of your life. So many of these Fridays now for the last almost 3 years. It's been incredible to get to be together. It is one of the highlights of my week to get to spend it. I love when I see SADS Live on my calendar. And I look forward to the new year to be with all of you again. And we will be together again on January 6th for a special New Year's resolution, yours and mine, and your question and answers. So that's January 6th. And then as we have 8 remaining days of 2022, go to our website, www.sads.org. Top right corner, I think it's in the top right corner, donate in red, and click it and give a year-end gesture of your appreciation and gratitude, or tell a friend to give, or tell the rich aunt, rich uncle to give and make a difference. I can promise you that we are very careful and very wise stewards of your gift, where we try very hard to put it to good use to fulfill our mission. And I know that as we come upon one of my most favorite seasons of the year, Christmas, which is one of the holiest holidays for those of us of the Christian faith, that I do wish you a Merry Christmas. For those who just finished celebrating the start of Hanukkah last week, a blessed Hanukkah. But Christmas is for the Christian, one of the most sacred and holiest of holy days, of holidays, where our blessed Creator, God Almighty, incarnate, Emmanuel, God with us, sent his Son. For God so loved the world that he gave his only Son, that whosoever should believe in him should not perish, but should have everlasting, eternal life. So we're grateful for what Christmas means. We celebrate it. We celebrate it with everyone throughout this country of ours here in the United States and throughout the world. And as you celebrate with time and family, I wish you a blessed time together. But I'm very well aware that given our community of SADS, that a gathering of families, there may be an empty chair. I just recently saw a beautiful family, two little children with their daddy and their grandpa, whose mom just died not too long ago, 9 months ago, and whose grandma died 3 months before that, just before Christmas of last year. So I'm well aware that for some families, this is not a celebration time. This is a reminder of profound agony and grief. And I hope that even for those families, there can be a respite from that, and somehow a joy beyond imagination could even settle into that family's heart and soul during this time. For those where we have caught it and we've diagnosed you and we've treated you and we have short-circuited the threat of awful, then we celebrate, don't we? Because awful did not happen and won't happen if we have something to say about it. So whatever state it finds you in, thank you for choosing to spend time with us at the SADS Foundation. Merry Christmas, Happy New Year, and see you on January 6th.